Central Nervous System Tuberculosis Part 2. Investigations and Management. Presented by Dr. Jalil Mohsin Uddin, DTCD, FCPS Pulmonology, Associate Professor, National Institute of Diseases of Chest and Hospital, Dhaka. Routine investigations. 1. Complete blood count CBC, checks for infection, pyogenic, viral, or tubercular, and anemia. 2. Erythrocyte sedimentation rate ESR, an indicator of prolonged infection or inflammation. 3. Blood sugar, as DM is an immunocompromised condition and require good control to limit the infection. Routine investigations. 3. Liver function tests, necessary because many anti-TB drugs are hepatotoxic. 4. Renal function test, example, serum creatinine, as CKD is an immunocompromised condition and require for adjustment of dose of drugs. 5. Serum electrolytes, especially if there is confusional state. Investigations for risk factor evaluation. 1. Chest X-ray. This is a key screening tool, as there may be evidence of miliary tuberculosis, and about 50% of TBM patients have evidence of current or past pulmonary TB on a chest X-ray. Investigations for risk factor evaluation. 2. Tuberculin skin test, TST or IGRA test. A skin test for TB may be performed, for the evaluation of presence of Mycobacterium tuberculosis infection, but other tests like IGRA are preferred if available due to limitations of TST. Investigations for risk factor evaluation. Quantiferin TB Gold test, it detects the body's immune response to TB bacteria by measuring interferon gamma IFN gamma produced by T cells. HIV testing, recommended, especially since people with HIV are more susceptible to CNS involvement. Sputum for AFB or gene expert, rarely positive if there is disseminated tuberculosis PTB plus TBM. Specific investigations. Key CSF findings in TBM. Appearance, often clear but can be turbid, forming a fine spider web cobweb clot pellicle when left undisturbed due to high protein. Cell count pleocytosis, elevated total white blood cells 100, 1000 cells L, predominantly lymphocytes, though neutrophils may dominate early stage. Glucose, low hypoglycemia, typically 45 mg DL or 50% of blood glucose, as bacteria consume it. Specific investigations. Key CSF findings in TBM continue. Protein, significantly elevated 100 to 500 mg DL or more due to blood-brain barrier damage. Protein content may be still higher in case of spinal block. Very high protein concentration is associated with worse prognosis. Acid-fast bacillus AFB smear culture, low sensitivity. AFB smear can be positive in 10 to 30% cases. AFB culture may be positive approximately 45% T0 70% cases. Specific investigations. Key CSF findings in TBM continue. PCR expert MTB-RIV, highly specific but with suboptimal sensitivity, helps guide treatment. Estimates of sensitivity varied widely and ranged from 51% to 100%. Adenosine deaminase eta, levels can be elevated, varying by age 10 to 12 IU. Comparative findings of CSF in various diseases: viral meningoencephalitis, acute bacterial meningitis, tuberculosis, meningitis, fungal, normal. Opening pressure, normal high, 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 high very high, 10 to 20 centimeters. Color, gin clear. Cloudy. Cloudy yellow. Clear cloudy. Clear. Cells mm3. Slightly increased. High very high. Slightly increased. Normal high. Differential. 5 to 1000 lymphocytes. 100 to 50,000, 25 to 500. 0 to 1005. Neutrophils. Lymphocytes. 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 CSF plasma glucose. Normal. Low. Low very low. Normal low. 66%. Ratio. 30%. Protein GL. Normal high 0.5 to 1. High. 1 high very high 1.0 to 5.0. Normal high. 0.45. 0.2 to 5.0. Normal CSF opening pressure is generally 20 cm for adults, 10 cm for children below age 8, but may be as high as 25 cm. Whiteley et al., Neurology 2006, 67:1690-1. Key MRI findings: meningeal enhancement. The most consistent finding is diffuse, thick, linear enhancement of the leptomeninges, particularly in the basal cisterns after contrast. Thick, linear, nodular, or patchy enhancement indicating inflammation exudate. Can start focal and become diffuse, or vice versa. CSF abnormalities: altered signal intensity, hyperintensity on flare T2 in CSF within basal cisterns and sylvian fissures, sometimes with CSF locculation. Basal meningeal enhancement arrow with multiple punctate enhancing lesions diffusely involving the cerebral hemispheres and cerebellum arrowhead. Key MRI findings: tuberculomas. Tuberculomas appear as focal dark lesions on T2, often showing a target sign bright center with dark rim or ring enhancement after contrast, reflecting caseation and edema, differentiating them from other masses. They can be solitary or multiple, appearing anywhere but commonly in the cerebrum, cerebellum, and basal ganglia. Cranial MRI changes in tuberculous meningitis. Tuberculoma in T1 contrast images A and B. Key MRI findings: hydrocephalus, dilation of ventricles due to CSF flow obstruction, often seen early. Cranial nerve involvement, enhancement and thickening along cranial nerves, especially the 3rd, 5th, 6th, 7th, and 8th nerves, leading to palsies. Cerebral infarcts, due to vasculitis, seen as restricted diffusion or parenchymal signal changes. Key MRI findings: ventriculitis, ependymal enhancement lining of ventricles. Spinal involvement if included, leptomeningeal enhancement, nerve root clumping, arachnoiditis, or myelitis, inflammation of spinal cord. CT findings in brain tuberculoma. A brain CT scan for tuberculoma typically shows round lesions with prominent surrounding edema, low density, often appearing as a central low mixed density area, necrosis, liquefaction with a brightly enhancing ring after contrast, resembling a target sign especially with calcification. CT helps monitor treatment, showing lesion shrinkage with anti-TB drugs. MRI is more specific, showing characteristic T2 hypointense dark solid tuberculomas, distinguishing them from tumors. Contrast-enhanced CT at the level of the cerebellum shows a tuberculoma with central necrosis in the left cerebellar hemisphere with surrounding edema. Marked edema is also seen in the left frontal region. There is midline shift with effacement of the 4th ventricle and dilation of the right lateral ventricle. Management of tubercular meningitis. The duration of treatment for TB meningitis is 12 months because of uncertain penetration of the blood-brain barrier by some anti-TB drugs. Initial adjuvant corticosteroid therapy with dexamethasone or prednisolone should be used. CSF penetration of anti-TB drug. First-line drugs pyrazinamide. Activity. CSF penetration. Cidal. 95 to 100%. Isoniazid. Cidal. 90 to 95%. Ethambutol. Static. 10 to 50%. Streptomycin. Cidal. 10 to 20%. Rifampicin. Cidal. 5 to 25%. Second-line drugs. Activity. CSF penetration. Linezolid. Cidal. 80 to 100%. Ethionamide. Cidal. 80 to 95%. Moxifloxacin. Cidal. 70 to 80%. Levofloxacin. Cidal. 60 to 80%. Cycloserine. Static. 40 to 70%. Amikacin. Cidal. 10 to 25%. Kanamycin. Cidal. 0 to 43%. Standardized treatment regimen. TB diagnostic category. Type of patient. Treatment regimen. Intensive phase. Daily. Continuation phase. Daily. New case. CNS tuberculosis, TB meningitis. 2HRZE. 10HR. Previously treated case. TB meningitis, neurological TB. 12HRZELFX. Use of corticosteroid. It is recommended that all patients with TB meningitis, an adjuvant corticosteroid therapy with dexamethasone or prednisolone should be used. The drug most frequently used is prednisolone, in a dosage of 0.5-1 mg/kg daily, increased up to 2 mg/kg daily in the case of severely ill patient, for 4 weeks. The dose of prednisolone should then be gradually tapered down at 2.5 mg every week over 4 to 8 weeks, 1 to 2 months in total duration. Alternatively, dexamethasone can be used as an adjuvant therapy for CNS disease. The recommended dosage is 0.1 to 0.2 mg/kg day depending on severity of the disease for 2 to 4 weeks, followed by gradual tapering of the dose. How steroid acts. Corticosteroids are used in CNS tuberculosis TB primarily to reduce severe inflammation and swelling in the brain and meninges, which helps lower intracranial pressure, decrease the risk of death, and prevent long-term neurological damage, complementing anti-tuberculous drugs that target the bacteria. How steroid acts. They manage the body's overwhelming immune response inflammation to TB antigens, preventing complications like hydrocephalus, spinal cord damage, myelitis, and vision loss, leading to better outcomes for patients, especially in tuberculous meningitis TBM. Key roles of corticosteroids in CNS TB: reduce inflammation. They suppress the intense inflammatory response that damages brain tissue, blood vessels, and meninges. Lower intracranial pressure (ICP). By reducing swelling, steroids decrease pressure inside the skull, a major cause of death and disability in TBM. Prevent neurological deficits. They help prevent permanent issues like paralysis, focal neurological deficits, and cranial nerve palsies. Improve outcomes. Studies show corticosteroids reduce mortality and severe disability in HIV-negative patients with TBM. Surgical management of complications of CNS tuberculosis. Surgical management of CNS tuberculosis TB complications addresses issues like hydrocephalus, abscesses, and mass effects not resolved by anti-TB drugs, involving procedures like shunt placement, VP shunt, EVD, abscess drainage resection, and lesionectomy, often for diagnosis or decompression. Surgical management of complications of CNS tuberculosis. Key surgical goals include relieving pressure, obtaining tissue, and improving neurological outcomes, with techniques varying by location, e.g. stereotactic biopsy, craniotomy. Outcomes are generally good with sensitive drugs, but surgery is vital for intractable cases or uncertain diagnoses, often bridging to or complementing medical therapy. The MRI and intraoperative situation of a tuberculoma. Common surgical procedures and indications. Shunt placement, ventriculoperitoneal VP shunt, for persistent hydrocephalus, worsening ICP, or deteriorating sensorium despite medical treatment. External ventricular drain EVD, an acute measure for high CSF protein or before a VP shunt. Endoscopic third ventriculostomy ETV, an alternative to VP shunts, especially in chronic phases. Ventriculoperitoneal VP shunt. Common surgical procedures and indications. Abscess drainage aspiration, to reduce bacterial load and decompress the brain. Resection excision craniotomy, for large tuberculomas, obtaining tissue or removing lesions causing significant mass effect, especially if unresponsive to drugs. Stereotactic biopsy craniotomy, for precise diagnosis and management of deep-seated lesions. Key clinical messages for CNS tuberculosis. The core message regarding central nervous system tuberculosis (CNS-TB) is the need for high clinical suspicion and prompt, empirical treatment to prevent severe neurological damage and death, as definitive diagnosis is often delayed due to challenges in detecting the bacteria. Thank you all. Tuberculosis. Central Nervous System Tuberculosis Part 2. Learning Pulmonology.